For those of you that don't watch a lot of TV, Sports Center is an hour-long show, usually daily, on ESPN, the sports network, and they do a top 10, top 10 plays of the day or top 10 plays of the week. So I thought I'd kind of use that as a model to do some top plays in nephrology that have a urology slant. I do have a disclosure for this talk. I get to sleep with this beautiful woman every night, so she's my wife, and she's also a nephrologist. So I don't claim to have a lot of nephrology data or intelligence in my head, but after 25 years of sleeping with this lady and hearing all her calls in the middle of the night, I swear if I had to, I could give dialysis orders. Absolutely. 2K bath, all that stuff. I know it, frontwards and backwards. All right, let's get started. We'll see how this works. So one of this question, I think we all give IV fluids, and this question has been around for years and years. IV fluids have been around for 200 years, right? Is should we be giving saline or balanced fluid? So there have been 4 really big trials, big news in the nephrology world. I've written them down here, the split, the salted, the basics. They have all these crazy names, but it's literally greater than 42,000 patients in a variety of either ICU settings or in an ED setting. And they randomize these patients to either saline or these balanced fluids. The balanced fluids are something like lactated ringers. So balanced fluids means they're lower in chloride. They have some sort of buffer, so whether acetate or lactate, and then there's some electrolytes with them. And so the outcomes for these studies are usually AKI, death, how long till someone actually dies, because these are pretty sick individuals. But overall, the quantity of the fluid is much more important than the quality, and these balanced fluids cost about twice as much. So if you're not going to see a benefit and the cost is twice as much, it's a wash. So you can give saline in most instances, except for 2 instances, and that's TBI and hyperchloremia, which most of us don't manage. Number 9. This question actually came up the other day. I forget who asked it when we were having our afternoon discussion about the consequences of shockwave lithotripsy. And this is the paper that started it all. So Amy Krambeck was a resident at Mayo Clinic with Joe Segura at the time. And she sent a questionnaire and got replies from 288 shockwave lithotripsy patients. And she also sent a very similar questionnaire to stone controls who had never had surgery. And what she found was an increased odds risks of hypertension and diabetes. And here we are, 15 years later. There have been multiple studies that basically have refuted this data. I put this one up here. This is one of our critique panelists, Manoj Manga's data. And if you go to the EAU guidelines, it says very clearly this relationship is unclear, published data are contradictory. However, no evidence exists to support the hypothesis that shockwave lithotripsy may cause long-term adverse events, and that's where we are in 2023. Number 8, hopefully these aren't too fast for you because I got to get 10 in. I like this question. So how much renal function is lost during a PCNL? This was actually asked to me by a patient. I was just, made something up, of course, what we always do. But then I'm like, boy, I guess I better look this up. So this is a really cute paper. These authors did a technetium-99 study, which is very similar to a DSMA. It's supposed to be better than a DSMA. Measured creatinine, and then this is all retrospective, but they looked at the patients that had 1 single-tract PCNL and 2 multi-tract PCNLs. Very young population of patients at this center. And then 3 months later, they got the technetium-99 scans again and measured creatinine. So the short of this is a single-track PCNL, at least in their hands, lost about 3 mLs per minute of eGFR decline, a total of about 1.25%. A multi-track was about 4 mLs per minute, or about 3% total functional decline. Now, these groups weren't exactly the same. Obviously, if you're doing a multi-track, their stones are larger, so there's some confounders there and maybe a little bit of bias. But in general, I can now actually say to that person, you can expect your eGFR to go down about 3 or 4 mLs per minute. Number 7, so there's been this big buzz, particularly the last 10 or 15 years, about papillary grading systems. So I think probably most of the people in the room are familiar with Randall's plaques. So you put a scope up and you see these, white plaques sitting on the papilla. This is kind of high, medium, and low here. And there's lots of other things that have been phenotyped over the last 10 years or so. So the big ones now are plugging. So instead of the white plaques, the plugs are yellow. There's pitting, which are basically spots of where stones used to be present and now have broken off. And then there's contour loss. So we've all seen the beautiful renal papilla that look like nipples, and then, over time they get flatter and flatter, and pretty soon, it's just completely flat. So there are now 2 scoring systems, in case any of you are interested. The European system is like the T, M, and N staging for cancer. The American system just is a visual scale. So 0 to 1 for all 3 of these categories. So that scale is 0 to 6, and then an A, B, C. And you say, well, that's wonderful, but how does that use clinically? We still can't really figure that out. So in extreme cases, particularly with plugging, it's calcium phosphate, it's hypocitraturia, and hypercalciuria. For plaque, higher surface area, so more surface of the papilla covered by plaque, correlates to more stone numbers and more stone events over time. And then overall higher scores are CKD and brushite stones. But really, this is still used as a research tool for now. But we're going to continue to try to make this clinically useful. Number 6, in a group of stone formers, can a spot urine approximate a 24-hour urine? So we talk about this all the time. These individuals actually did this study. So this was a group in Italy and a group in the U.S. just published a couple of months ago, where they took adults, they collected a 24-hour urine. At midnight, they asked them to fast, and then the first morning void, they took an aliquot of that urine as the spot, and then compared this to the 24-hour values. Now, to do that, of course, you need to be able to estimate what's in that urine sample from a concentration standpoint of creatinine. So they came up with 4 different methods. One is probably what they thought was the best. Well, let's look at the creatinine in the sample and the creatinine overall. That's the ratio. And they did one where they just estimated someone's creatinine based on their weight. They did one where they just said everyone's 1 gram and everyone's 1.5 grams. So they tried all these different formulas. And this was what they came up with. The correlation coefficients were pretty lousy. I love that there's uric acid, there's a piece of meat by it. You see that? It's kind of cute. But otherwise, it didn't really correlate what they thought would correlate well. However, the subset of the Americans in this study from Tufts University did 2 separate ones. They did a morning fast like the Italian group, but then they did a preprandial and a postprandial. And you'll see the oxalate on the preprandial and the fasting citrate appear to be more reliable and have a lot more highly correlated to the 24-hour urine study. So perhaps those 2 studies, oxalate and citrate, can be used for population-based studies where people are just banking urine. Maybe we should be doing more spots instead of 1 if we really want to know, but in general, it looks like the first morning spot urine is not a great substitute for a 24-hour value. You guys still with me? This is it. We're getting to the top half of the top 10. So what's up with race and CKD equations? So this is something that I asked my wife about because you kept seeing this in the news, right? So these are the 3 equations that are used to calculate eGFR, or glomerular filtration rate. The Cockcroft-Gault is not used clinically. It is a research tool. But when you get your creatinine at whatever lab or hospital you use, and there's that little eGFR beside it, that number is either generated by the MDRD or the CKD-EPI equation. Now, as you can see, these have a race modifier. So these race modifiers were really developed to try to account for the historical observed differences in serum creatinines in blacks versus non-black study participants. So these are people that when they participated in the study, they were trying to make these formulas, and they said, this makes the formula work a lot better. Really, over the last 5 to 6 years, there's been a lot of controversy over the use of these race modifiers. And basically, they look like they're unsubstantiated, and they really lack a biological basis. So this was a big study in the nephrology world. It's published in the New England Journal of Medicine, November of 2021. The CKD-EPI people kind of saw the light, and they said, well, let's see if we can create a CKD-EPI 2021 creatinine without race, and it actually works better than any other creatinine-based equation that's ever been published. And I'm going to show you an example. So I just went to MD Calc. I don't know if you guys use MD Calc, but it's got lots and lots of formulas. And you can actually select what you want for creatinine. So I selected the 2009. I put a female, 72 years old, creatinine 1.3 with a race of black. And her EGFR is stage 3A CKD with a 48. So we're going to put down that little table there. So then I did the exact same thing. I just, in the race, I put non-black. And look at that. She's now stage 3B CKD with an EGFR of 41. So exact same parameters using that, the old equation. And now I went back up and I selected the 2021. And as you can see, there's no longer a race criteria. So it's just gender, age, and creatinine. And she is now a stage 3B 44 EGFR. So you say, Canales, that's all very interesting, but what kind of practical does this mean for me? Well, if you do donor nephrectomies, this probably is going to mean that there's going to be a slight decrease in the amount of people who can actually donate, or donor candidates. For non-blacks, we have actually decreased their CKD diagnosis, and that might mean that some people have to wait a little longer on the transplant list. But for blacks, this actually has increased the CKD diagnosis. This means earlier referrals to nephrologists, earlier interventions, earlier medications, and with one snap of the finger, literally the stage 4 to 5 CKDs changed from at 0.05%, meaning that 1 in 2,000 qualified blacks were now listed for transplantation sooner. So all the advocacy groups, ASN, KDIGO, all those groups really feel like this has leveled the playing field for CKD and ESRD. Number 4. So I give a lot of kidney stone talks, and the biggest question, one of the big questions I always get is, should I do 1 or 2 24-hour urines? So of course, I never answer that question. I say, well, here's this study. So this is Ciro Andonian. He's a very smart urologist in Canada. He had an idea to look at, I think this is around 400 patients in his clinic who have done 2 separate 24-hour urines. And he said, I'm going to look at the discrepancy between the first and the second, the absolute discrepancy, whether it was high, whether it was low, and plot it. And if you draw a line at 25%, it almost touches every single one of those. Meaning, if you're someone who just gets 1 24-hour urine, understand that those values can be 25% higher or 25% lower if you're just doing 1. And of course, if you get 2, you're going to have a better way to average those. But I think it's a good way to think about it. You don't necessarily need 1, but understand that those values may not be completely correct. We're getting there, guys. Number 3, smart bottles. Anyone here have a smart bottle? Use a smart water bottle? Do you guys know what these are? So what I'm showing here is the Hydrate Spark. This is a very popular water bottle in that you don't have to open the app. So most apps on your phone, you actually have to open it to engage it. This one just works by Bluetooth. And it's fairly accurate, and it glows when you haven't been drinking enough. So this is the water bottle that they're using in the Big Push trial. This is literally a multi-million-dollar, multi-institutional trial of the NIH. But this group did a smaller trial. So this is Mike Borofsky at the University of Minnesota. They did a multi-institution 12-week study. He wanted to recruit 150 individuals. I'll show you how many he ended up recruiting, but very noble. They had to be stone formers, and they had to have a 24-hour urine with low volume, and they consider low volume less than 1.5 liters. Primary outcome was 24-hour urine volume at 6 weeks. This is a 6-week study, and then they took a survey 6 weeks later. So literally, this is a 3-month study, right? This is their flow diagram, their patient randomization. It's a little hard to read, but basically on the left side of the screen is the smart water bottle, the right side is the dietary recs, and this is the orange arrow is really what's important. They were able to get 22 people in the smart bottle and 28 people in the dietary recs. So out of the goal of 150, they got 50, and they had to close the study early. But still, they got some data. So here's the data. The people who took the smart water bottle were able to increase their urine volume about half a liter more than people who were just told to, drink lots of water. They also saw a slight increase in their urine pH. When the patients actually did the survey, they said, yes, the water bottle helped me remember to drink more than the people in the dietary rec arm. So, a half liter increase in urine volume in 6 weeks' time is not all too notable, I would say, because stone formation is a lifelong disease, but it's a start, right? This bottle does have some problems. Sometimes it's hard to calibrate. The technology fails. The Bluetooth doesn't sync. A 40% non-compliance rate in this study is really troubling. I mean, this is, you can't get any shorter than a 3-month trial. And then what's the overall effect on stone risk by increasing by half a liter? It's hard to say. These things are a little costly, and of course, if you leave it in the room when you leave, it's gone, right? So, I think the question, the jury's still out on smart water bottles. Number 2. So this study shocked me a little bit. Is that 20 minutes? Okay, God. Whew, okay. So I don't know if you guys are familiar with the STONE study. This was a study of tamsulosin for urolithiasis in the ED. It's a great acronym. This was a study where they randomized people to Flomax or placebo. So a few years ago, that was a really popular topic. So this is a secondary analysis of that data. What these authors did, they said, okay, let's look at all the people that got a CAT scan when they were passing their stone and a CAT scan 30 days later. And let's see who passed it and who didn't pass it, and are there some characteristics? So you guys can imagine what the characteristics are. So the people who failed to pass their stone presented with stones that were in the proximal ureter and presented with stones that were larger, right? That makes complete sense. If you have a 6 millimeter proximal ureteral stone, you're less likely to pass it than a smaller distal stone. And then they said, okay, let's get those 43 individuals and look at the surveys they took at the end of the study. 36 of those people had no pain and were requiring no analgesia. They all felt like they'd passed their stone. 26 had no hydronephrosis by CT, and 23 had no pain and no hydronephrosis. So I don't know about you guys, but this is what I do in clinic. So a month later, I see them, I think I passed my stone. Are you hurting? Nope. Ultrasound looks good. See you later. So if you do that routinely, there's a 13% chance that that stone is still sitting in the ureter. You say, well, that's probably still just little small stones, right? Well, there were a few small stones there that probably would pass, but 13 of those were actually 5 millimeters or greater. So this was a little scary to me when I read this study, and this study just came out a couple of months ago. So I think you have to have that, informed decision-making talk with your patient and say, look, if you're not going to get a follow-up CAT scan, just understand there's about a 13% chance that we're missing a stone in your ureter. And maybe this is also the role of a dipstick. It's so easy, just dip their urine. If there's still some blood there, maybe you should get a CAT scan there. All right, number 1, mannitol during partial nephrectomy. How many here use mannitol during a partial? I'm raising my hand because I still do it. All right, so maybe 6 or 7 folks. So there's a lot of data. There's some very good basic science data, a list of the data. This is dog studies. I tell it to all my residents because none of them have read any of these studies. But in the dog studies, there's increased renal blood flow, but the perfusion pressures are the same. So you're kind of getting more bang for your buck, getting more blood supply to the kidney. And of course, it's a free radical scavenger. The cons is this is a new medication. There's anaphylaxis. If you give it in really high doses, you can get electrolyte abnormalities. And the biggest con is no one really knows if it works. So this was a paper published 5 years ago out of Memorial Sloan Kettering, where they randomized 200 individuals undergoing a partial nephrectomy to either mannitol or a similar dose of saline. The primary outcome was creatinine and eGFR at 6 weeks and 6 months after the partial, with the secondary outcomes of EBL complications, and they did renal scans in these individuals. So just from a demographics, about 80% of these people were men. The mean tumor size was 2.8 centimeters, so very similar to what Jay was talking about today. We're operating on small renal masses. Shocking to me, only 40% of these were done by MIS, so 60% of these were done open, and all but 3 were done on clamp. So this was the graph of the whole paper. No statistically significant difference between the mannitol group and the placebo group, and overall, you lose about 7 to 8 mLs per minute of eGFR after a partial nephrectomy. So, of course, there have been hundreds of editorials written about this, major paper. A lot of these patients had cold ischemia. That's a confounder. The dose of mannitol that they used was kind of wimpy. That's a confounder. A lot of times if you give mannitol, you also chase it with Lasix. They didn't do that. And then they recruited, average EGFR was 86, so healthy kidneys. So of course, if you get a lot of healthy kidneys and you do something to them, they're probably going to recover and do just fine. So it was a little bit of a selection bias. But this is practice changing. So there's just a recent article that showed that 70% of urologists are no longer giving mannitol, and a lot of that is based on this one paper. So I'm throwing it out there so you know. To summarize, I think the major of these points of this top 10 was a persistent ureteral stone with a negative renal ultrasound and no pain 13% of the time. Smart bottles work, and it's really hard to recruit stone formers into studies. Mannitol is not necessary in the setting of normal renal function. I don't think that's too crazy to say after seeing a high-quality paper like that. And then an EGFR loss, and of course we're going to all use the new CKD Epi 2021 without race, is about 3 to 4 mLs per minute for PCNL, about 7 to 8 mLs per minute for partial nephrectomy, and we can all feel comfortable using saline compared to balanced fluids. Thank you very much.